Good evening, one and all. Today, I'm here to talk about obstructive sleep apnea, the myths and the facts. March 15th, every year, the second week of March month, we'll be celebrating the Sleep Equity for Global Health. This day is celebrated on Friday before spring vernal equinox of every year and is participated by over 70 countries. During sleep, our body repairs tissues, consolidate memories, and regulate hormones. There are several phases of sleep, each with a distinct role. While snoring in the sleep is fodder for memes in India, indicates a very serious health problem. As per new AIM study, as many as 104 million Indians suffer from sleep apnea. This disorder can cause severe respiratory diseases like which will come up with snoring and other medical conditions as well. Today we have with us Dr. Srinivas Kishore sir, who will give us briefs about sleep apnea and their conditions. Hi sir.
Hello, good evening everyone. Good to meet you all this way. And for those of you who are going to watch a recorded version of this, good morning, good afternoon, good evening, or whenever you're watching this. Today happens to be a very auspicious day because for those of us who are involved in helping people breathe better, especially during their sleep, this happens to be a very important day to improve the awareness of the problem, especially of sleep, and also about impaired breathing during sleep. Thank you, Monica, for a wonderful introduction. And as you clearly said, this is a global problem, and hence it's celebrated across the world to bring about awareness. And as you actually brought it out and alluded to earlier, this has become a major problem, especially in India. And in India, the prevalence rate is much higher than in the States or in China or in the UK or Australia. In India, it has been found out that we have a prevalence rate of 32%, which is very high with our billions of population. So the prevalence of the disease is out there. It's just that we have to pick it up. Go ahead.
Yeah. So, sir, I'll be asking you few myths about obstructive sleep apnea. So, what is obstructive sleep apnea? How does it differ from a regular snoring?
So, if you really look at the differences between snoring and obstructive sleep apnea, there is one word that I would always like to say. Every snorer can be a sleep apneic, but every sleep apneic need not necessarily be a snorer, because there are other kinds of diseases where, in spite of there is absolutely no kind of air going in. For example, there is a condition called obesity hyperventilation syndrome, wherein they are not sleeping, they are awake, but their breathing is dysfunctional. So they don't necessarily have to be sleeping. But for a snorer to develop sleep apnea, they necessarily need to be choking in your sleep, resulting in a breathing disorder, which we call as obstructive sleep apnea. Obstructive means there is an obstruction for the free flow of air. Sleep means in sleep, and apnea is inability to breathe. So, snoring can be a cardinal and essential sign for obstructive sleep apnea.
Thank you, sir. Thank you for answering. So, can I ask you the second question? How can I tell if I might have obstructive sleep apnea or not? What could be the common signs and symptoms for a layman to understand about it?
So, if a person, so let's just divide it into for children and for adults. If you have an adult and the person is snoring, as soon as the person hits the bed, irrespective of what position they are in, that is a red flag for us. This basically tells us that the patient has, or the person basically has, impaired breathing, either because of some obstruction that is happening in the upper airway, or because of some kind of a block happening in the upper airway, making it hard for that person to breathe. Whenever there is this kind of a scenario in the patient or in the person's upper airway, it becomes difficult to breathe, and hence they manifest in the form of snoring. The second cardinal sign that you should be looking for is what we in textbooks are called as witnessed apneas. Means when a person is asleep and the person is snoring, if the air is not going through the upper airway and the person is actually choking, what you would see is that there will be a pause in the breathing, and the snoring which was there would stop, but there will be a lot of effort that the sleeping partner would visualize when the person is breathing. In the sense, there will be an increased work of breathing. That means the chest and the abdominal movements would vary, but there won't be any air that's coming from the nose and the mouth. That is telling us that the person is actually choking. That is the second red flag. The third red flag for an adult is actually getting up multiple times in the middle of the night. A lot of conditions can cause this, but one of the most important conditions that makes a person wake up in the middle of the night to pass urine is a condition called nocturnal enuresis. So nocturnal enuresis means in the sleep they're waking up to pass urine, and that's another flag for obstructive sleep apnea. These are the cardinal 3 or 4 symptoms where a sleeping partner can actually pick up and say that this person is not breathing properly during their sleep.
Thank you, sir, for letting us know the main cardinal signs of obstructive sleep apnea. Can I know the causes of this obstructive sleep apnea? And is there any risk factors that increase the likelihood of developing it?
So that actually brings us to the symptoms which are the daytime symptoms. Now, if the person is actually having a fragmented sleep, like how we just spoke about, that the person is not breathing properly. When a person is not breathing properly, obviously the quality of this sleep gets affected for this particular individual. Hence, what happens when that individual wakes up in the morning, one, he is not very happy to wake up. The moment he wakes up, he is not filled with energy to jump out of bed. So he is very sort of lethargic to the fact that he has to get up and go about with this day. So one of the commonest symptoms, in fact, of this kind of sleep fragmentation that happens during sleep results in what we call as EDS, also known as excessive daytime sleepiness. So this individual actually has no energy, feeling fatigued, feeling tired, feeling like taking a nap whenever possible. So one of the commonest problems would be for a person to sleep off during their work. Now, if it's a car driver and the driver is falling asleep when the car is driving, it's bad for the passengers of the car, it's bad for himself, and also for the people on the streets. Point number 2, if the person that we're talking about is a loco pilot or an airline pilot, their judgment would be very clouded, obviously causing putting the lives at risk and threat. If these are the immediate complications, a lot of them are actually cardiopulmonary problems. For example, there is an increased chance of heart attacks, there is increased chance of drug-resistant hypertension, there is increased chance of what we call as rhythm disorders of the heart, and also a lot of impact on the brain, especially working memory, as we call it. That is, recent memory gets affected, your judgment will get affected or get clouded. And the term which we came to know recently and became very common after COVID, which is brain fog, is one of, again, very common symptoms of obstructive sleep apnea.
Thank you once again, sir. Sir, I also wanted to know more about the demographics of this OSC disease. Is it more common in male or female, or like vice versa in children?
An excellent question. In fact, I was actually waiting when you would come to that question. Now, every disease does not present the same way in both the sexes. For example, obstructive sleep apnea. When you talk about obstructive sleep apnea and you talk about the male, you are talking about a huge person who's slightly on the obese side, who may have a chin which has gone back, or somebody who's got a big waist, who has a very high BMI. These are the typical or cardinal signs of a person having obstructive sleep apnea, or the cardinal male when you look at that person. But it is not exclusive to the big fat male. It is also, it can happen to people like me, for example. If you have, the problem is about the tone of the upper airway. It is not about how the person looks. Similarly, in a woman also, it's the same thing, because women are normally not as big or not as obese as men. But till menopause, they are guarded by estrogen. The moment they hit menopause, the symptoms or the disease, which is obstructive sleep apnea, can affect men and women the same way. However, in men, the symptoms of obstructive sleep apnea are more like excessive daytime sleepiness, having brain fog, having symptoms which are tend to be more lethargic and dull and things like that. Whereas in women, the symptoms or the presentations are very different. In women, the problems are more, again, fatigue, symptoms which are related to dizziness, symptoms which are related to facial pain, body pain. More often than not, most women, the obstructive sleep apnea presents in symptoms which are very vague. Like I just alluded to, that means a facial pain which is not getting controlled with any symptom, lack of concentration, feeling listlessness, not having slight dizziness throughout the day, not being able to concentrate. When they sit up and get up, having slight dizziness, cold, clammy feet and hands, so on and so forth. In fact, the symptoms that we need to ask a woman when you are suspecting sleep apnea in the premenopausal age group is very different than the symptoms and signs that you would look for in a male for obstructive sleep apnea.
Okay, so there is no difference between male and female. They just differ with the symptoms, appearance of symptoms.
Yes.
Thank you,
that's
sir.
correct.
So, what happens? What would be the potential health consequences if this OSA is untreated?
So, primarily, obstructive sleep apnea manifests in two broad ways, right? One broad way is because of sleep fragmentation. Now, what is happening? Because the person is unable to sleep or is not, see, it's all about the quality of sleep. It's not quantity of sleep, right? You may be lying in bed for 10 hours, but not sleeping for various reasons. So, this impaired quality of sleep results in what we call as sleep fragmentation. As you know, sleep is not a single stage, but has multiple stages. So, for example, in the initial few hours of sleep, you are getting what we call as deep sleep. This is very, very restorative for the physical well-being, all right? Whereas in the later part of the sleep, one gets what is called as REM sleep or rapid eye movement sleep, which is very important both for mental and physical well-being. So, the moment that doesn't happen, or it doesn't happen in the quantities that it should happen, it results in what we call as neurobehavioral problems, right? If these neurobehavioral problems are on one side, the inability to breathe or the increased work of breathing actually results in what we call as cardiorespiratory problems. So the basic consequences of not breathing properly and not having good quality of sleep will result in either having neurobehavioral problems or having cardiorespiratory problems or having both of them together. And hence, for example, because of these neurobehavioral problems, what happens is a person becomes very agitated. The person would get very irritable. So even if you're asking the person a very simple question, he's biting back at you, for example. Then as a person who's asking the question, say, why is he responding the way he's responding? So you would actually see a change in the behavior of these individuals. Somebody who was calm and cool would become very anxious, very agitated. They would have memory issues because they keep forgetting things. And these, because of this impaired quality of sleep, they are more vulnerable to very dreaded conditions like strokes, right? Which can land up in very bad CNS problems. On the other hand, the cardiorespiratory problems are more in lines of myocardial infarctions, also known as heart attacks, rhythm disorders, that means arrhythmias, so on and so forth, things like increased pulmonary artery pressure. But primarily, the consequences are the biggest problem. It's not the condition itself.
Okay, thank you, sir. How is OSA diagnosed? What are the diagnostic tests which we can, emphasize that whether we are having OSA or not?
So actually, the evaluation starts at home. So and that is why this awareness drive is very important, because the most important thing here is that if you are suspecting a breathing disorder in a particular person, what is very important is there are about 80 sleep disorders, okay? Disorders that can involve a condition called insomnia, just sheer inability to sleep. And in fact, insomnia is the commonest sleep disorder. The second commonest sleep disorder is sleep-related breathing disorder. Now, sleep-related breathing disorder is a bigger spectrum of condition wherein primary snoring, obstructive sleep apnea are types of sleep-related breathing disorder. So, when you're talking about sleep-related breathing disorder, like I said earlier, the actual part starts right from at home. So, if a person is sleeping, the person is having restless sleep, the person is twisting and turning, if the sleeping partner feels that there is something wrong with the person's breathing, that is when you need to meet your medical specialist to evaluate for this particular condition. Because you can only evaluate this in a hospital setting. But having said that, since a person may not be very comfortable in a hospital setting to do the necessary tests to evaluate the severity of the disease, nowadays more and more emphasis is being given to what we call as HST or home sleep tests, wherein the sleep study which actually gives the grading for the severity of the condition can be done at home in the person's comfort zone to tell us how bad or how severe the problem is. For example, this actual evaluation, also known as sleep study, tells us the need for treatment and also tells us the urgency of the treatment.
Okay, so thank you. So, what are the available options, treatment options for OSA?
So, based on the severity of the problem that you would know on the sleep study, it is divided into mild, moderate, and severe. In mild conditions, you have a plethora of things that you can do. For example, you can do lifestyle changes. For example, if a person is obese, or if a person is having problems with their sleep hygiene. What is sleep hygiene? Sleep hygiene is nothing but your inability to sort of unwind your day to get into bed. Most of us with busy lifestyles have that very poor sleep hygiene. That means you come home, you have a late dinner, you sit down with your gadget, you're either watching something in social media, so your brain is not winding down. See, this is a contrasting different fact compared to what happened to us before the electric revolution, wherein people used to sort of wind down as the sun went down. But now, because of all the industrial revolution and thanks to the light bulb, we illuminate ourselves with light and we just don't fall asleep. If light is one factor that causes problems, the rest of the problems are our blue light emitting gadgets, which constantly keep your mind and brain awake, resulting in poor quality of sleep. And that is why this is called as poor sleep hygiene. So, if you have a poor sleep hygiene or you have a very poor bodily outfit, problem with obesity or BMI or things like that, you can work on that with exercises and so on, diet and so on and so forth. But based on your sleep study, if you are in the moderate or severe category, you may have to think about more invasive kind of treatments, wherein either you have to consider getting yourself a mandibular advancing device, or to evaluate why there is an obstruction, to get a thorough ENT evaluation to see why the air is not going inside your body. You can get something called a non-invasive treatment called CPAP, which is continuous positive airway pressure. And also you can think of a procedure or a surgical procedure based on how bad the situation is. But having said that, if you have a patient with lot of symptoms, like I said earlier, women have very mild sleep apnea if you do their testing, but the symptoms may be many more. So does that mean you will not treat that particular individual? You will have to treat that particular individual. So in such patients, you can actually give something which is minimally invasive, like a mandibular advancing device or positional therapy for that matter. Just changing the posture and position of a person during sleep can actually alleviate the problem. So, basic thing is that one size doesn't fit all is the mantra in the management of obstructive sleep apnea. There are a plethora of treatment options. You will have to customize the treatment to that particular patient's needs and the patient's expression of the problem and the patient's manifestation of their or the underlying mechanism which is resulting in the manifestation.
Okay, thank you, sir. As you have mentioned that changing in sleep positions can help OSA. Is there any specific sleep positions?
Yes. So the sleep study will tell us that. For example, some people naturally tend to sleep to one side to get a better quality of sleep. That's how your brain sort of thinks that it's better for you to sleep on one side. So if a person is naturally sleeping to that side, it's telling you that the brain is actually telling you to sleep better. This is telling us that the person can breathe better in that particular position. All right. Now, is that the best position? We will know on the sleep study based on how the air is entering into that person's body. For example, people who have obstructions in the nose for that matter tend to sleep to one side. And this particular patient who can sleep better in one position or their symptoms get better in a particular position of sleep are called patients with positional sleep apnea. Right? This is very different from a person having regular sleep apnea who choke irrespective of their sleep. So, if there is a patient with positional sleep apnea, it is very prudent that you work up in the nose, because patients who have nasal obstruction as their problem have, or they're highly likely to be having positional sleep apnea.
Thank you, sir. Sir, are there any medications which can worsen OSA?
Very good question again. See, and I would like to bring alcohol as a medication, right? And why I bring this to this discussion is primarily because a lot of my patients actually say, sir, I'm not able to sleep. Not knowing why they are not able to sleep, they consume alcohol every night just for them to go to sleep. But alcohol-induced sleep is the worst sleep that you can get. Because remember, I said that sleep is not a single segment. Sleep is not a single stage. There are multiple stages. And in one of the stages of sleep, there is a stage what we call as REM sleep, or rapid eye movement sleep, or also known as dream sleep. In dream sleep, what happens is all your muscles get very relaxed. And if you are taking a drug, whether it is alcohol or any drug, that is actually bringing or making the dream sleep longer, or bringing it faster in terms from the onset of sleep, automatically your disease would get worse. That means the disease burden would get worse, and hence your quality of sleep would get ruined. And because the alcohol makes the muscles more compliant, as we call it, that means they become more relaxed. The airway collapses more, and the airway becomes more choked, and hence you would choke more and your disease would get worse. So if you are having alcohol to go to sleep, not knowing why you are not able to sleep, you are actually making your condition worse. The other drugs that can also make things worse for a person having sleep related breathing disorders are all the medicines that we take to go to sleep, especially a class of drugs called benzodiazepines, and they're also anxiolytics. A lot of people sort of take these medicines to calm themselves down, to sleep off, especially over the counter. People just go to the pharmacy, and that is the policy in India, unfortunately. They go to pharmacies or their friendly neighborhood doctor, who would, not understanding why they are prescribing the sleeping medicines, give them that. And if by unfortunate situation, if the person has obstructive sleep apnea and if they take these drugs, they are putting themselves at great danger, causing more problems. And like I said, all the diseases that can result in the form of as a result of obstructive sleep apnea would get worse.
Okay, thank you, sir. Sir, a patient named Raj, he is 35 years old. He sleeps every day for 5 to 6 hours with a minor snoring activity. He'll have dizziness, along with that in the morning time he'll have excessive sleeping which he cannot control. These are his common complaints.
Right.
In the background, he also has anxiety and panic attacks.
Right.
He is worried about OSA.
Right. So, age is never a criteria. Earlier, we used to think that it only affects the older people, but age is never the criteria. Even a youngster can have sleep apnea. So, what is very important is the fact that his symptoms are across the table, right? There are symptoms of anxiety which can also coexist as a comorbid condition to OSA. His symptoms are also classical of OSA. So, this becomes a situation wherein you need to sort of, if this is a soup bowl with multiple vegetables in it, we need to take out and segregate the carrots from the peas to the other vegetables. to see what is causing the entire symptom and what is the driving force in this particular individual. So, in order to find that out, evaluation is the key. A thorough ENT examination is very important. Once an ENT examination is done, we have to quantify the seriousness of the problem by doing a sleep study. Only then we have found out the cause of the problem and the severity of the problem, and then we can connect these two things to the symptoms and say, okay, this symptom is happening because of this particular problem, and hence we'll be able to come out with the different treatment options for this particular individual.
Thank you so much, sir. Sir, let me ask you a last question. Are children also more prone to OSA?
Yes, I think we missed that. Like I said earlier, sleep apnea is not a disease which is exclusive to adults. Nowadays, because of our lifestyle and the kind of food we eat, there is an increase in sleep apnea in kids as well. Now, sleep apnea in kids manifests in many ways, and it manifests based on age. For example, if you have a young child, 3-year-old, 4-year-old, their problems basically will be the kids will be very hyper, the kids will be super cranky, they will develop what is called as nocturnal enuresis, means somebody who has been potty trained will go back to passing urine again in bed. They cannot control their urine, they will be sleeping in class, things like that. As the child grows older, and if God forbid because of our lifestyle obesity sets in for that child, obviously the symptoms will be very different again. Their scholastic performance will go down. That means the school grades will keep going down because the memory goes down, their concentration goes down, and more importantly, they will be having facial changes. That means skeletal changes that will result in their face becoming very long. Because one of the commonest causes for pediatric sleep apnea is adenotonsillar hypertrophy, which is adenoids and tonsils which are in the airway, clogging up the airway, making it difficult for the children to breathe. Hence, a proper ENT evaluation and management can yield very good results in kids.
Thank you so much, sir, for letting us know all the facts about OSA.